Well, tonight we have the very distinct and wonderful honor of having a very good friend of mine who I deeply admire and who has mentored me through some good faculty teaching of our medical students, Dr. Brian Wolfe. Brian is an associate professor of medicine at the University of Colorado, and he obtained his medical degree from Johns Hopkins in 2001 and completed his residency and chief residency at Dartmouth Hitchcock Medical Center in 2005. You're old. Prior to joining the hospital medicine division at the University of Colorado Hospital here in 2010, he held academic appointments at Vanderbilt and Temple Universities. He serves as co-director of the Advanced Practice Fellowship, which is an innovative year-long program that trains nurse practitioners and physician assistants in the art of inpatient medical care. He is a compass guide within the School of Medicine, working with 20 students longitudinally, supporting their development through coaching, teaching, mentoring, and advising. He serves as medical director of the Dawn Clinic, which you may have heard of. It's a student-run free clinic treating uninsured adults in Aurora, Colorado. Nationally, he's a member of the American Board of Internal Medicine Maintenance of Certification Examination Development Committee member. Outside of medicine, he's on the board of trustees for his alma mater, Emory, and for Henry College. Most importantly, he serves as a taxi driver to his 14-year-old daughter and his 11-year-old son. It's my pleasure to welcome you tonight, Dr. Wolfe.
That was a very kind introduction. I'm really excited to be here tonight. I've never actually lectured to a lay audience, and so I normally just put medical students and residents asleep in these same chairs. So I feel honored to be here and to be with you. What I would suggest is if you have questions, thoughts, things you want to share, experiences you've had, please feel free to interrupt me and share. Obviously, the folks online will have to depend on our assistant to help me understand what their needs are.
Oops. If you raise your hands, I'll come bring the mic to you if you have questions. At 10 till we'll also break for questions.
And of course, right off the bat, I'm not able to advance these slides.
Marcos.
All right. I can do it by hand. Okay. It's all right. All right. Actually, I think the slides are just kind of stuck. So I'm not even advancing here.
Problem with that. That's weird. It's sharing.
Hand it over to the technical folks. So I'm super excited to talk to you about pneumonia tonight. I think it's a disease that most of us have interacted with in one form or another, with a loved one, with someone else. There's some complex things that happen, and as Joe pointed out, how old I am, things have changed so much since I graduated medical school that even in preparing for this talk, I realized, wow, there's just so much new knowledge and hopeful change in the future. Oh, sorry. Okay, that's fine. Okay. So my learning objectives tonight are stated up here. So to have a broad understanding of the pathophysiology, that's the term we doctors use to talk about when things are broken in the body, how they're broken, of how pneumonia works, understand some of the pathogenic causes of pneumonia, and then know an approach to prevention, and hopefully talk around some other things. So what do? I'm an internal medicine hospitalist. So that used to be a word I had to define at every single audience I went to. I think most people now have interacted with a hospitalist, but essentially I take care of adults who get admitted to the hospital and have general medicine, non-surgical problems. So heart failure, pneumonia, kidney problems, you get a doctor like me. So I'm a generalist. I'm certainly not an expert in any specific area. I went through 4 years of medical school and then 3 years of internal medicine training. For those of you who are interested in the practice of medicine and kind of how it all works. And then folks like me either go out and be a generalist, and both Joe and I are generalists, or you go on to subspecialty care. So my wife is a gastroenterologist, so she did 3 more years of training after that. As I said, I was a hospitalist at Vanderbilt, Temple, and now Colorado. But I want to take you back a few years. That skinny guy up there, this is my graduation from medical school. If you notice that little piece of paper in my hand, that actually allows me to go out and take care of patients, which is just frightening. It was terrifying to my parents. At the time, I was uber confident and I thought I looked pretty good in my fancy robes. God knows, I didn't know people could be that skinny, but I'm certainly not that way anymore. But don't worry, in case you were worried, my ego was not in check. I have an uncle who's a professional artist. He's passed now. But my uncle Zim also drew caricatures on the side, and he was kind enough to send me this picture, which is probably more reflective, the overly tall, the short white coat that doesn't even cover my belt. I don't know what he means about Dow Jones, but and the skull off there is a little bit disturbing, but I just wanted you to know that my ego wasn't too big, and I was pretty nervous. I was starting out, I was going to be a doctor. I was going to start to use that title. And for many of us, that's a huge transition. I was moving to another place. I moved to the beautiful town. Does anybody know where this is? So this is Dartmouth Hitchcock Medical Center, which is in beautiful New Hampshire. It was like moving to summer camp. It was gorgeous. There were trees everywhere. That's literally my hospital. And as beautiful as the hospital as I worked at here, this was more beautiful. There were literally hiking trails out the back doors. But it was a serious place. There was serious business. And my first rotation, so as an internal medicine resident, so I would do a lot of different things. But one of the things you get is practice in the emergency department. So you would spend, and my very first month was in our emergency department. And the very first patient I saw, I obviously changed the names here, is Janet Becker. And Janet Becker is a 68-year-old woman, and she had been feeling poorly for the past 2 weeks. And she was presenting with cough, fever, and some weakness. And I remember specifically where Janet was placed into a room, and my attending at the time, Mark Hampers, who was a very talented emergency medicine doctor, and Mark said, go in there and see her. And I was so excited. This is the first patient I'm ever going to see as a doctor. And I went in, and she looked pretty uncomfortable, and I felt pretty bad and maybe a little out of over my head for my first day on the job. And I remember putting a stethoscope on her and listening to her. And these were the things we noticed right away. And she was pretty ill appearing. She had a high fever. Her heart rate was really fast. She was breathing fast. Her blood pressures were pretty low. I did a physical exam, and I was really excited about using my physical exam. I come from a place that taught it deeply. And I pulled out my stethoscope and I was listening to her lungs, and I didn't hear any breath sounds on the left side. And I remember being excited about that in the sense that I was using my skill set, and also a little embarrassed as a novel doctor that this woman was clearly in a lot of distress. And I was kind of excited to be part of her care team. And I think there's that constant tension as doctors, as we're interested and we're fascinated with how the body works and how it doesn't work. But at the same time, we're human beings, and most of us are here because we really wanted to help the person in front of us. And that's the doctor I wanted to be. So we got a chest x-ray, and this is what we saw. So normally the air will fill up the lungs, and air on a chest x-ray is black. What's it? Oh, sorry. All the stuff on the right side is black, and that's normal lung, that's air. All the stuff on the left that's white, that shouldn't be there. And there's lots of different things that can cause that whiteness. It's usually blocking the x-rays, and that's why it looks white. But in this case, it was pneumonia. And so what did we do with Janet? Well, we took her into the hospital. We provided her with extra oxygen since her oxygen levels were low, and we started antibiotics. Despite this, her oxygen levels continued to fall. And because of that, she had to go, the fancy word is endotracheal intubation, and put her on a mechanical ventilator. Most of you probably heard the term ventilating, so she was placed on a ventilator. And despite the very best of our care, she moved to the ICU. She died 8 days later. And so this really struck me. This was a woman who was just out walking around Hanover, New Hampshire. These are hardy folks. They're hardy folks in Colorado, but I tell you, folks in New Hampshire are pretty hardy, live free or die kind of folks. And here had taken this woman who was totally fine, had been sick for a couple of weeks at home, put off going to the doctor, as most people do, and especially most New Hampshireans do, and then came in, and within 8 days was dead, despite the best medical care. And that was really community-acquired pneumonia, and that's really what inspired me to think about this talk, as it was the very first case I saw. And I've been fascinated with pneumonia and both the things we can do and sadly the things we can't do to help people in this situation. So we'll pivot now. We'll talk a little bit about the history, the science, and the epidemiology of pneumonia. So pneumonia's been around a really long time. In 400 BCE, so it was described by Hippocrates, the same guy that gave us the Hippocratic Oath, as this disease process, and he described it as even old in that time. Now, most people thought back in these days that pneumonia was a secondary disease, so something else was wrong in the body, and pneumonia was sort of a secondary response. And it wasn't until the 1870s that we actually realized bacteria were involved in many of the cases. And Sir William Osler, who was one of the founding doctors and is considered the father of modern medicine, he's gotten some blowback recently for some not so couth things he said back in the day, but he still left us a lot to learn from in terms of medical history and medical approach. And he would talk about pneumonia, and he was famous for this quote: "In children and healthy adults, the outlook is good. In the debilitated, in drunkards," I apologize, we certainly don't use that kind of language now, "and in the aged, the chances are against recovery. So fatal is it in the latter class, i.e. the elderly, that it has become termed the natural end, the end of the old man." And that's really where this term comes from, if you've ever heard pneumonia, an old man's friend, and because there are many ways to die, and pneumonia was a pretty kind one, and they honestly didn't have any treatment for it. We're talking a lot about pneumonia, and I think we all have a sense for it's an infection, but what is it more specifically? Well, pneumonia is actually a couple things. So it's actually inflammation, usually in the air sacs, which we call alveoli, that fill up the lungs. And it's often associated with infection. It doesn't have to be. There's actually non-infectious causes of pneumonia, but it's typically caused by bacterial viruses. And so for those of you who have seen it or have had it and experienced it, it's often been a bacterial or viral pneumonia. To understand this, you have to understand a little bit about the anatomy and physiology of the lungs. The lungs just aren't big sacs of air. They're actually a big sac of a whole bunch of tiny sacs. So I love these. Kids are lazy these days, right? In the old days, you have to fill up one water balloon at a time, but now you can buy these packs and plug this thing into the sink and just fill up all these water balloons at once. So I just say, the new generation, man, they've got some struggles if this is how they fill up water balloons. But it's actually a really good model for what alveoli or air sacs within the lungs look like. Because essentially the lung has tubes that break into tubes, that break into tubes, that break into tubes, and they get smaller and smaller and smaller until they get out to these really tiny tubes. And at the end of each one of them is a sac, and it's not full of water, it's hopefully full of air. And the balloon itself in this model represents cells that are stretched around the outside of it that have blood vessels running through there. And essentially this is how the lungs work, or when it doesn't work, where it doesn't work. And here's sort of the example. So the diagram simply is this is a blood vessel, so that blue line up at the top is deoxygenated blood. So blood that the oxygen's been used up by organs, by muscles. It's gone back to the heart pumps it to the lungs, and now it flies by the lungs. And because these balloons are really small, the blood is right next to the air, and the air actually exchanges, and carbon dioxide goes into the air sacs and oxygen goes into the blood, and it's picked up by hemoglobin molecules and red blood cells, and it's carried back out to the body. Now, these things are really small. It's hard to imagine how tiny they are. They are less than, they're many can fit in a single millimeter. So all these sacs are so tiny, and that allows the air to be very, very close. In fact, if you took an inch of the lung, by an inch of the lung, by an inch of the lung, you just took a piece out and you were to measure how many of these little alveoli sacs, any guesses how many there would be? In an inch by an inch by an inch? Come on, give me a guess. 10? Huh? 1,000, a million, about 2.5 million. So 2.5 million, there's something like 480 million, depending on who you believe, per lung. That's a whole lot of these, and it's just fascinating. I just want to step back. I mean, this is why I became an internist, is because I get so excited about this. I mean, our body is so complex. There's no way we could design a system, nanotechnology aside, whatever, in which we put 2.5 million of anything into an inch by an inch by an inch. And that's in all of your bodies right now, taking in oxygen, blowing off CO2, maybe starting to slow down your breathing as you're getting bored and falling asleep. No, but anyway, it's really cool just how much goes in this. In fact, if you took all those sacks and you spread them out, what I learned in medical school, all those little sacks next to each other could cover a tennis court. Now, of course, anything like that, you say something like that in medicine and somebody's going to be out there to debunk it. And sure enough, people have debunked that a little bit. Well, it's about half the tennis court. So this guy over here, if you spread out his lungs all over there, it would take up the entire half tennis court. And that's what you need for air exchange. So that's how much surface area you need with air and blood right next to each other with just a really thin membrane between to exchange enough oxygen and carbon dioxide to keep you moving, to keep all your body organs functioning, because you need oxygen in every single organ. Now, your lung protects itself in many different ways, but I wanted to at least highlight this one, and it's called the mucociliary defense. And so I'm going to orient you a little bit. Let's see if the pointer works. Yeah. Oops. Oh, now the thing's working. No, I can't go backwards. Oh, my goodness. Oh, my goodness. I'm falling apart here. All right. So this is a cell here, and this is where the air is going in and out. So this is the tube that we sort of cut in half. And what the cell's done is it's produced a couple different layers. So kind of this watery layer here and this more mucus layer. So we think about mucus being bad, but you actually have mucus all the time. And it's critical to your life that you have that mucus. And so then they have a blown up section, and all this stuff is these are sodium and potassium, and these are all active pumps pumping in and out of here to give the cell energy. But the cool thing here are these little hair-like things that go up and down here, and they're attached to little motors, and they take a ton of energy. But what they do is they essentially wave, and it's called a metachronic energy that they have, and they move the mucus up and out. And so mucus and bacteria and anything bad that you breathe in actually gets caught in these layers up here. And then these cilia wave that fluid up, and it moves it up, up, up. And so they wave in a particular direction. Here's a little bit better picture where you can actually see them waving. And they're moving the dust particles out, and that includes bacteria or everything else. And so this is one of the many important ways that our lungs stay clear of problems, because those little bitty, any collection of fluid or anything in the body can easily get an infection in it. Our bodies weren't meant to collect fluids. And so those alveoli sacs are highly dependent upon this entire system to keep us healthy. And we'll come back to why this becomes important. So how does pneumonia actually happen then? Well, understanding all of that, the first model I'm going to show you is what I learned in medical school, which is honestly wrong now, is that we used to know that we've always known that there's bacteria up here. So the nasal passages, what we call the nasopharyngeal passages, have bacteria up there, and they live there all the time. Sometimes they get out of control. Most of the time they're normal, just like you have bacteria on your skin. I hate for any germaphobes out there, I apologize, but we are just covered in the stuff. And we used to think that everything below pretty much the vocal cords was sterile, meaning there was no bacteria down there. And so the model was strep pneumonia, which we'll talk a little bit more about, is a very common, it's the most common bacterial cause of pneumonia, and you would pick it up. So oftentimes like a 2-year-old would come home, they'd have a new little snotty infection, they'd bring some strep home, mom or dad would breathe that in, it would get up in the nasopharyngeal passageways, and then it would microaspirate. And all that means is you get a little bit that would slip down inside your vocal cords, get down into the lungs. It gets past that mucociliary defense. It gets past your white blood cells and everything else and sets up shop down there, and then would slowly build an infection. And because there weren't bacteria down there at all, it would be able to take over, and that's what caused pneumonia. Well, how many of you have heard of the gut microbiome? Come on, you've watched the Today Show. It's all over the place, right? The gut microbiome. Pharmaceutical companies are already out there selling you drugs to make that gut microbiome better. We don't really know what we're doing. We don't know that much about it, but people are making a buck on it. Well, there also is a pulmonary or lung microbiome. And so I'm going to describe step by step what's going on in this slide. No, I'm not at all. But pneumonia is way more complicated because it turns out we were totally wrong. So we have these really bad methods of trying to grow bacteria, and we would take samples from low down in the lungs and we put them on a plate and then we grow them out. You've all seen those plates that was on one of my earlier slides. And if things grew there, that means there were bacteria there. If they don't grow, then there were no bacteria. Well, it turns out that's dead wrong. There's just lots of things that don't grow well on those plates that grow really well in your lungs. But you have bacteria in your lungs all the time. Here's a whole bunch of names of things that are living in your bacteria as we speak. And they have really important jobs. And there's this thought, there's this homeostasis. So there's this way that they're doing their job, they're living their lives, they're interacting with your body, your immune system, and everything's kind of keeping everything going. And it's all healthy. And then something happens, or you have a chronic lung disease like COPD, or you have some scarring in your lung, and there may be even some interaction between the gut microbiome, something changes in here, and then everything's amiss. And so the reason I point out this slide is now there's lots of different bacteria. They're meaner bacteria, bacteria that don't do as well and don't play well with your body. And now there's all this inflammation and other damage, because what really happens is pneumonia. When we looked at that picture on that x-ray, most of what we were seeing, that white stuff, was not bacteria. Most of that's water. Some of that's blood, some of that's white blood cells, but most of that is our body's response to infection. The bacteria get down there, and then all of a sudden, your white blood cells migrate in, your immune fighting proteins start to act, and it starts to leak out blood. And the body's trying to do the right thing. It's trying to fight infection. It's bringing its infection fighting cells. And the quickest way to do that, right, is to open up those blood vessels and let those blood cells drip right in there. But the problem with that is it's a bad response, because now it's blocking up those alveoli. Now it's scarring them down. And it may be even causing problems and dripping over into the entire body, so that inflammation within the lung can spread quickly throughout the body. And I point out all of this. I point out all of this because now we know, yes, we still need to develop new antibiotics, and we'll come and we'll talk more about antibiotics as we get into the talk. But now we have a bunch of other targets. So some of these bacteria lay down these special films, which you can kind of think of, they literally, I swear to God, in fancy papers, in the most fancy papers, they call it slime. How technical. Everybody complains we're so technical. Well, somebody had their laugh because they didn't call it something fancy, they called it a slime. And these slimes actually help protect the bacteria and allow them to grow fast. Well, guess what? There's new targets for us. There are things other than antibiotics that we potentially could give to help treat pneumonia. Now, have any of these come to fruition? No. We're still at the very beginning of this. I literally pulled up a Harrison's textbook, which is kind of the cornerstone. Harrison's is the textbook. Like Dr. Fauci used to be the editor of Harrison's. It's about yay thick. You can only find it in electronic form. And in 2015, I looked up the version, and right down at the bottom, it said, there may actually be some stuff going on here that we don't know about. It's like there are bacteria there, microbiome. They threw around the word, and it literally is like 2 sentences. I pulled up Harrison's from last year, and the whole section is completely about this, because this is where medicine's going, and our understanding of it's just at the beginning. We're very nascent in that approach. So what are the complications? So why is it problematic? I'm sure you've seen people with pneumonia, it feels bad, but why does that stuff happen? Well, the first thing is, as those air sacs get filled up, they can't do their job anymore, because now you're literally where the oxygen and carbon dioxide should be exchanged. I think I have a picture here. Yeah, so this is normal alveolar tissue on a slide, blown up many times. And so these are alveolar, those little sacs. And then this is the wall around them, and these are either blood cells that have just got caught and are traveling through, but most of these are actually lung cells that actually form the walls of the lung. And so you can see in that x-ray, right, why it looks so black, right? All the x-rays are just going to go right through this stuff. There's not a lot of stuff in the lung, but compare that to a lung that has pneumonia in it. I don't think it takes you to be a microbiologist to say, this is really different, right? Look at all this stuff in here. Most of this is like blood cells, bacteria that have died, white blood cells. There's just some detritus in there. And if you notice, actually, even the walls are thicker. And that's because the walls have dilated because, again, that inflammatory response, and white blood cells have migrated in there. And white blood cells are infection-fighting cells. They're trying to do the right job. But now large parts of the lung are not doing its job anymore. So aeration, what we talk about where that air moves in and out, is not happening. Hypoxia. So hypoxia is just a fancy word for saying when the oxygen in the blood cells, so that diagram I showed you now, those red blood cells are carrying less and less oxygen out to the body. Well, the body really needs that oxygen. Organs specifically like the brain, the liver, the kidneys, they really need oxygen to perform their normal functions. And so when they aren't able to get enough oxygen, they start to malperform. And this is where people get kidney failure, or they get liver injury. And so I think as a hospitalist, I'm often explaining when someone comes in with pneumonia, why all this other stuff is happening. Well, this is why, or this is one of the reasons why, is actually oxygen is not getting around the body. And so those organs are no longer able to do what they're supposed to do. Bacteremia. So if this is a bacterial cause for pneumonia, then these bacteria have great access to the bloodstream, and now sometimes they'll get into the bloodstream and start to spread around the body. And some bacteria are really good about this. You've probably heard of Staph aureus, which causes a lot of skin infections. Well, when it gets into the lung, it's very good about getting into the bloodstream and vice versa, from the blood to the lungs. And so it can spread throughout the body. And you can imagine if infections in one part of the body versus all over the body, that's much more problematic. So bacteremia is a big problem. Another one is sepsis. And I think sepsis, I had trouble understanding what sepsis was as a medical student. And I imagine you've all heard about sepsis, and we know it has to do with bacteria. But sepsis is a pretty complex interaction. And essentially what it is it's not just bacteria causing infection. It's the inflammation that our body develops. And it's a dysregulated response. So it's appropriate, like when you get an infection in your skin, you will get some swelling there and it'll get painful and then it'll get better. And that's normal. That was an inflammatory response to an infection in your skin, totally normal. But what happens in sepsis is when things get dysregulated, when the inflammation sort of takes on a part of its own, and it starts actually altering blood flow throughout the body. It starts messing with our metabolic products, meaning we may be eating and drinking, but we can no longer metabolize that food and use it in a normal way. So sepsis is a really scary thing. It's one of the most common diagnoses, and it's one of the more common diagnoses of death in the hospital, often secondary to another disease like pneumonia or other infections. And then one of the most dreaded ones is ARDS, or the acute respiratory distress syndrome. And the way I think about it is it's very similar, but it's just happening in the lungs. So remember I showed you that infection was just on one side. So she had an infection on one side of the lung. But if you generate enough inflammation, what happens is your body's own really dysregulated response, and it develops ARDS. And when we take x-rays of ARDS, it ends up they have infiltrates or those same sort of fluffy white stuff on both sides of the lung. And so oxygenation goes way down. And ARDS is really scary. Around 1 in 3 people with ARDS don't survive 30 days. And so once that happens, and we don't have great drugs to prevent it. So once it starts happening, we just have to kind of get patients through it and hope the body heals. No single drug has ever been shown to reverse ARDS. In fact, that's one of the big problems in the body, period. We don't have good drugs to tamp down that inflammation, whether it's sepsis, whether it's ARDS, or whether it's just an infection like pneumonia. We always struggle to decrease the inflammation in the body. So what are things that raise your risk for pneumonia? Well, there's a ton of them. I bring up smoking and alcohol use disorder. Both of these are particularly interesting because they cause a bunch of things. Often people that smoke and use alcohol, or one or the other, often have poor nutritional habits. They often have put them at risk. They inhale the smoke, and there's lots of badness there. But going back to that mucociliary defense system, you can actually show if you give nicotine to those ciliary cells, they stop moving. And so if you've ever heard of the disease that children get, cystic fibrosis, that folks are born with, one of my good friends has cystic fibrosis. He has the same problem. His cilia don't work. And essentially smoking actually just creates a similar situation to like cystic fibrosis where those cilia just aren't moving. So now those particles build up, pathogens stay down there. And so there are many other ways that smoking can cause problems, but that's one of them. If you smoke long enough, or if you're unlucky enough to have a genetic cause, COPD or emphysema can cause problems. Essentially, both of those are loss of lung tissue. So if I showed you a picture of a COPD lung and we sliced it, what you would see is actually more air and less of those cellular bodies. So there's just a lot of open spaces. And they also tend to have dysfunctional breathing tubes that are dilated and they don't move air in and out well. And they often don't move pathogens in and out. Older age, unfortunately, as we get older, your risk for pneumonia just goes up. And nothing reverses this. In fact, older age is one of the highest risk factors for pneumonia. And so as we get older, we're just unable, no matter what our nutritional use is, no matter that we never smoked and we never exposed, we take great care of ourselves. Unfortunately, as we get older, our cilia don't work as well, our defense systems don't work as well, and we're just at higher risk. Viral respiratory symptoms. So we used to think that people would go out and get a virus and then that would cause pneumonia. It's a little bit more complicated, but that's probably a true statement. So when we think about pneumonia, often we talk about influenza and how many people it killed in the Spanish flu. Well, most of those people actually probably died of pneumonia. The flu came in, got them very sick, weakened their immune system, created that abnormal place, that non-homeostatic area in the lung, and then they ultimately develop pneumonia. Other things, asthma, dementia, chronic heart disease actually is a risk factor. And then certainly things that are immune compromising, so especially uncontrolled diabetes and diseases like cancer and HIV. Pneumonia is an important cause of death. So when we look at deaths, I went back to 2019, so this wouldn't be interrupted by COVID. But when you look at the deaths by age, heart disease is still the biggest leader, although it's dropped significantly as heart care has gotten so much better. Cancer still remains a big player, and a big group is other causes. So there's lots of different causes. But if you go down the list, you get to pneumonia and influenza, which is around 2%. Well, that may not seem like much, but remember, about 3 million people die in the United States every year. 2% of that is from pneumonia and influenza, which I'm not great at the math, but I think that's around 60,000 people. So we're talking about a ton of people, that's 60,000 people who are often needing to be hospitalized, placed in ICUs. Needless to say, you know, that 60,000 only represents 12% of people, because about 90% of people get out of the hospital once they get pneumonia, but that's still a ton of hospitalizations. And this is both a morbid disease, and causes a lot of death, but it's also a very expensive disease. This costs you as taxpayers a ton of money. We spend a lot of money to take care of people, especially as they get older with pneumonia. So we'll move on a little bit to diagnosis and treatment. So the diagnosis, so we make it pretty simple. So do you have a good story for pneumonia? Do you have the cough, shortness of breath, fevers? Do you have any risk factors? So things like COPD. That said, many people with pneumonia never have any risk factors. I actually took care of an internist friend of mine not too long ago who's really sick in the hospital. He's the healthiest guy I know, the guy who runs marathons. So it can take people in the prime of their life. He did fine and got better, but it really took months of recovery. And then radiology, we in general define pneumonia by having an infiltrate on X-ray. And here's what an infiltrate looks like. And now that you guys have seen those other slides, you kind of understand what you're seeing. So these are that globbed in stuff, alveoli filled with junk, and the X-rays can't penetrate, and that's why it looks white. Just like the X-rays can't penetrate against the bones, and this is the heart here, can't penetrate completely through that. That's why it's white. When this is all normal lung here, this black stuff all around. We also, if you go to the emergency department and have breathing problems, these days you might get an ultrasound. Ultrasound is actually really good for looking at pneumonia. And sometimes we'll use CT scans, which is kind of a fancier versions of x-rays taken in a three-dimensional way. Pneumonia has numerous causes, but I think this is one of the more interesting slides. As I told you, we have now all these fancy techniques. We have what are called PCR tests, and we search out and try to find the pathogen. But I want to draw your attention to this blue box over here. So 2/3 of the time, no infection is identified. So we can't tell you what it is. So for those of you who work in anything in the medical care, there are certain antibiotics that work against certain bacteria. But this, 62% of the time, we can't tell what it is. 11% of the time, we get a bacterial infection. 22% of the time, this is viruses. That's flip-flopped. Back in the day, it used to be the other way around, where there were more bacteria. But due to vaccinations like the pneumonia shot, the Pneumovax, actually bacterial percentages have gone down over time. And then a small number of people have polymicrobial, and they're usually sick from other reasons where they have multiple infections. But 62%. So then how do we treat it? Well, we have to take a best guess. And so when we think about different kinds of pneumonia, we actually characterize where people get their pneumonia and sort of their usual symptoms. And so community-acquired pneumonia is the most common. And this is just if I go into the doctor like Janet did that day and said, I've just been living my life and now I'm sick. We call that community-acquired pneumonia. And so the antibiotics, remember the antibiotics are only going to treat that 11% that have a bacterial pneumonia, or maybe that 62% we don't know what caused it. But nonetheless, we treat looking for streptococcal pneumonia. And this is a particular bacteria that's been the most common cause for pneumonia for more than 100 years, back until we couldn't even measure it. Over time, it's gotten smaller and smaller and smaller. So it plays a smaller and smaller role, but we still basically treat and give antibiotics. The current one we're giving is ceftriaxone and azithromycin, if you got admitted to me on the hospital, basically trying to treat strep pneumo. Hospital-acquired pneumonia is a little bit different. So if you're in the hospital or you've been in the hospital recently, you get a different set of pathogens because both you're probably sicker if something else landed you in the hospital, but also because unfortunately, despite all the cleanliness policies we have in hospital, a lot of sick people there, a lot of different kinds of bacteria. And there, the one we worry about a lot is Pseudomonas, because Pseudomonas requires a broader spectrum antibiotic. And so we treat these with a different group of antibiotics. And then you've probably heard of MRSA, or methicillin-resistant Staph aureus. Got 10 minutes? All right. And so MRSA is another one that requires broad spectrum antibiotics. And then ventilator pneumonias, we will skip at this point. COVID, I am just going to give you this slide. You guys have heard too much about COVID. I didn't want to talk about COVID. I will say that there are some brand new vaccines. The vaccines are really effective. They've been shown to be highly immunogenic. And when we look at the people that died in the last year, only a quarter of them have been vaccinated with a new vaccine, meaning 3/4 of those people hadn't. Now, is that prove that the vaccine would have lowered that risk? It doesn't, but it's a very strong signal that these vaccines are still powerful. There's been a lot of talk about myocarditis. I will say this is extraordinarily rare. It's most common in young men between the ages of 12 and 19. And actually, the myocarditis is more common if you get COVID than if you get the COVID vaccination, which is a little different than most people hear out in the lay speak. And actually, the one associated with the virus itself is actually a worse form. That said, there are some really striking, scary cases, as is there is with any treatment that we offer, but those numbers are extraordinarily small. Antibiotic stewardship. I think it's really important that we at least briefly touch on this and say, it's really important that we take care of the antibiotics we have. We just don't have that many in the pipeline. There's been a few released over the last years. My PharmD colleague can tell you that we worry about this, that we're going to run into infections that we just cannot treat. And the reason is we overtreat things. Like if you go into the common cold to your doctor and you're like, Augment always clears me up. Come on, some of you have done it. Some of you have done it and you've said, this always makes me feel better. it's not probably a bacteria, and it probably would have gotten better on its own. And by taking augmentin for your common cold, you've probably raised the level of resistance in your community. So it's really important that we take care of the antibiotics. And in this country, there's so many good parts of healthcare, but one thing that's not is we're so litigious. Doctors like me are really worried about not prescribing antibiotics. And so we do a really bad job of protecting our antibiotics. But take all the antibiotics you get, don't take extra antibiotics, but think about antibiotic stewardship because we all play a role. And then very quickly, how many of you are allergic to penicillin, if you're willing to share?
Who is?
That's actually a pretty small number. So what I will tell you is think twice about it, because we know from data that most people who think they're allergic to penicillin are not. And in fact, the data looks like this, is that penicillin is the most common allergy. So about 1 in 10 people say it. 9 in 10 people are not truly allergic. And especially those people that said I had a rash or I had some sort of skin problem when I was a kid, almost all of those people are not allergic. And even of the one person that actually was allergic, what we call an IgE-mediated immune response, which is the serious one that you worry about 80% of those will actually wane over about a 10-year period. And so if you had a serious response, then take it seriously. If you didn't, go to your doctor, because it's not just important for you, for the population, but it's actually important for you. So there was a great study that looked at patients that had a penicillin allergy or they didn't have a penicillin allergy, and they corrected for everything else. So they made those groups as equal as possible, except for that. There's a 14% higher death rate in patients who have a penicillin allergy. You're asking, why is that? Well, probably what that is, penicillin and its relatives are the best antibiotics we have. They are powerful, active, they kill bacteria. And so often when we have a penallergic patient, we have to move them off that into something else that's not as effective or that's broader spectrum or may have a different complication profile. So for yourself, I would highly recommend reaching out if you say you're penallergic to do something different. We'll skip recovery for now. And so when we think about prevention, prevention is pretty simple. There's not a whole lot of things. You can't not get older. You can't not have some other genetic disease. You can take care of your diabetes, but most people who get diabetes are probably going to get it anyway. But things you can do is avoid cigarette smoking. It's very clear there's a clear relationship between smoking cigarettes and pneumonia and bad outcomes with pneumonia. And once you quit cigarettes, after a pretty short time of a couple of years, your risk actually goes back down fairly far, almost to the baseline as if you'd not smoked. But you have to quit and you have to stay away, and secondhand smoke is just as bad. Flu vaccinations every year. You have to get vaccinated from the flu. Every time we don't, and we have a bad flu season, our death rates go up, and they go up in part because of pneumonia. And finally, pneumonia vaccination. So not everyone's appropriate for pneumonia vaccination, but talk to your doctor. Think about getting a pneumonia vaccination if you're in any kind of risk profile group. Therapies on the horizon. I just want to talk about, when we went back to that fancy model and like fighting the slime, there will probably be in the next 10 years different drugs that aren't antimicrobial, so they're not just out there to kill bacteria, that will lessen the burden of pneumonia. We're not there yet, but I'm excited to think that there are different therapies other than just continually trying to compete in this ever losing battle of creating new antibiotics that you become resistant to and new antibiotics that you become resistant to. So hopefully we covered a few things today, have a broad understanding of the pathophysiology of pneumonia, talk about the pathogenic causes, and know an approach to prevention. And there's some of my references. But thank you for your time and attention. I'm happy to take any questions.
We'll take turns from the live audience first, and then we'll go to the remote audience and back and forth. So if you have a question, just raise your hand. I'll bring you the mic.
Talking about Is that, it's on, okay. In talking about antibiotic resistance, how much do you think it affects it that meats that we eat are treated with antibiotics? I'm just curious.
Yeah, I think I'm certainly not an expert in antibiotic stewardship, but we think that the antibiotics we give animals ultimately translates to impacting the bacteria that are out in society and ultimately infect us. So it's less probably the bacteria that are infecting a cow or a chicken that you're giving the antibiotics for, but those antibiotics, unfortunately, this spillover and they hit other bacteria, and that allows for resistant bacteria to grow and fill that niche. How much of it is, I don't know. Great question.
It's a little off the subject, but it's totally on the subject. I have a granddaughter that has PCD, total sinus inversus.
Okay.
And, she's doing well. She's 10. A lot of help out of North Carolina and here. But, the whole cilia thing,
Yeah.
what it is.
So I'll repeat the question. He was making a comment about his granddaughter having PCD, which is primary ciliary dyskinesia. If I'm
Right.
We're talking about the same thing. All right. And essentially, sadly, some people are born and their cilia just don't work. And they actually end up with the heart on the other side and the liver on the other side. So their whole body's kind of flipped around. But one of the bigger problems they have is they don't have the cilia to, again, clear the mucus. And it's through a complex mechanism. But we've both been able to better take care of our PCD and cystic fibrosis patients. But to be honest, we've depended upon those patients to learn so much about how the body, when it doesn't work, that we can apply broadly. So I'm always thankful to patients that unfortunately have to deal with these diseases, people that have to deal with these diseases and the processes. But I'm also thankful of their contributions to helping the wider public grow our knowledge and understand better how to help both them and the wider community.
Let's see, I have a question from the chat from Stormy Carson. So with dementia / Parkinson's and an ATC patient, with my family member, not being able to get up and move, does this increase the risk?
Yeah, we think there's probably several things playing a role. As people age, and especially when they develop dementia is a really hard disease, similar to the way I was sort of describing pneumonia as a disease process that causes problems far away. Dementia is similar. And when our brain stops working, what we see as loved ones is they're forgetful. They don't remember who I am. They get lost. They forget their keys. But what their bodies sometimes see is that maybe the passageways no longer separate their food from their breathing tube very well. And so not only are they getting micro aspirations, a little bit of stuff from the food tube into the breathing tube, but a lot of stuff. And so aspiration is a common, unfortunately, very untreatable way with dementia. We think that keeping people stronger, mobilizing, there's been great studies to say that folks that have stronger grip strength and are up walking around and participate in exercise programs have lower rates of pneumonia. It's a little bit harder to say, should that person with Parkinson's and dementia do that stuff? Because sometimes that stuff can be really hard to do. Because we just don't know, is it because those patients are walking that they got less pneumonias, or is it because they can walk that they got less pneumonias? Are they just less sick? So it's a challenging problem. I say always keep people as mobile as possible. But as dementia progresses, it's one of the more challenging problems is keeping the lungs protected.
So I had a teenage daughter who got what they call walking pneumonia at camp. And when we went to the doctor, the doctors listened, and then we went on antibiotics. So I guess my questions are walking pneumonia, what is it? Group, can you catch pneumonia in group situations like that more frequently? Like, is that? And then how often is it that you just get listened to and you get antibiotics?
Yeah, great questions, all of those. I get so excited about pneumonia, and I made a million slides and I cut them down and I still almost ran over. But one of the things, so there's sort of typical and atypical infections. I spent a lot of time talking about typical infections like strep pneumo, which typically it is contagious. These are all contagious infectious diseases, but it's not necessarily like when I have a cold or when I have COVID and I'm next to someone that I'm going to get it. But you do transmit infections that way. There are some pneumonias called walking pneumonias that look a little bit different on X-ray. Patients aren't quite as sick. They often have more of a dry cough. They often are more short of breath and tired. And actually the lung pathology looks a little bit different. So I showed you that picture where all the alveoli were filled up. Usually in walking pneumonia, there's less filling up of the alveoli, but the cells around it are really thickened and there's more of an inflammatory reaction. You can hear that sometimes. The stethoscope is not very powerful in terms of picking up pneumonia, so you can listen to a patient and not hear one. If you do hear one in a young patient who's otherwise healthy, yes, you can definitely make that diagnosis in the office. I typically would still get an X-ray. Sometimes, like in a student clinic, sometimes they don't have that ability, and sometimes cost becomes an issue. As I said, I'm the medical director at the Don Clinic, so sometimes we have to think a lot about costs. So you can get an antibiotic that way. I think in young people that's okay. It's not ideal. The diagnosis of pneumonia is usually one that's made radiographically or with an X-ray.
See, I have another question from online. This is from Brianna Simmons. Does pneumonia affect pediatrics differently than adults? And as a follow-up question, does pneumonia affect pediatric patients long-term?
Okay. So I will start by saying I'm not a pediatrician and I do not take care of little kids. Thank God I have my own, that's enough. Pneumonias are different because they're different pathogens in kids. And in fact, if you've got a pediatric talk for pneumonia, they'd actually break down and say, kids less than 1 to 3, 5 to 10, 10 to 12, 12 to 18. And in each of those groups, you could have a different kind of pneumonia. You've probably heard of RSV. RSV sometimes affects older adults, and it's actually rising right now. And it's one of the more common causes I see people that get admitted to the hospital with a pneumonia-like process. But little kids get RSV a whole lot, and it looks different in them. Pneumonias can lead damage to the lung. It all depends on the pneumonia. If you have a really severe scarring pneumonia that actually develops like an abscess, like when you've developed a collection of pus in your skin and it's drained, if you get that in, if it gets so bad that it gets like that, it can damage the lungs permanently, but it doesn't have to. And kids are darn resilient. So I've seen kids with really sick from pneumonias and actually grow up and have totally normal lives and have totally normal lungs. So I will step back and say, I am not a pediatrician and do not know much about pediatric pneumonias, but I will say the kids can definitely have all sorts of different outcomes similar to adults, some of which are completely normal after they recover from the pneumonia.
Audience question?
So you talk about your Dawn Clinic, and I kind of want to follow up with that. With what type of like public health efforts can you make when addressing pneumonia, besides like vaccinations and stuff in like low income communities?
I think working on smoking cessation, because smoking cessation is really hard. It's hard to ask people. I often care for people that are working 2 jobs, have stresses that I can't imagine, raising large families, maybe dealing with being undocumented. All those stresses, guess what? We all have different stress reliefs. Some people go out and run. Some people don't have time for that. Some people smoke and some people drink alcohol. And so figuring out ways to lower those stress levels, lower those socioeconomic burdens is probably our best hope at actually than just sitting down and saying, you need to stop smoking. You need to stop drinking. Vaccination efforts are really important. Often immigrant communities, and I'm speaking very broadly there, and I don't mean to make assumptions, but often immigrant communities can be very suspicious about things like getting vaccinations. There's a lot of misinformation out there. It can also be expensive. We have just a few occasional vaccines at the Don Clinic. Most of my folks I have to send off, and there's an expense there that probably for most of you is free on your health insurance plans, but some people have to pay out of pocket. So it's figuring out that, boy, we really benefit as a country in this place to supply all our folks with the basic level of care of figuring out those ways to get people off smoking, figuring out ways to get everyone vaccinated, because when we do that, we're all healthier and we lower the risk of the infection within large communities. Great question.
See, I have another question from online. Is there a simple allergy test available to test a patient that was allergic to both penicillin and Keflex in the past, which had caused hives?
Yeah, so there are actually great strategies out there. If you're really interested, you can pull up the CDC website and they have some really fine resources on there. I would suggest sitting down with a doctor and sort of talking through it. If people are fairly low risk, then oftentimes we actually just do what's called an amoxicillin challenge and give people amoxicillin in the office and see how they respond. And most of the time that works. If people are a little bit higher risk, then we do skin testing. I'm not an allergist, and there are some nuances to that, but there are lots of programs rising up now. And if you look for penicillin delabeling, if you Google that, there are local resources that you can look out for to get that off your allergy list.
And we have time for one more question. That'll be from the audience here.
So you talked about smoking cessation, Billy, really important.
That way.
Oh, there we go. Cool. So with like other methods, because you mentioned that nicotine itself interferes with this motion of the cilia, with other methods of nicotine delivery, like vaping or like patches or like dipping, do you think that those could also be risk factors for pneumonia? Do you think they're like less likely to be risk factors because there's not smoke or?
Yeah, the data around these is very mixed, and I will say that vaping probably carries the exact same risk. Dip probably carries higher risks for oropharyngeal cancers. Whether that has the same effects on ciliary, I honestly don't know the answer to that. If someone's using patches as a means to get off smoking, then I would highly support that, even if that nicotine does have some impact on ciliary function, just because ultimately our goal should get people either to lessen their nicotine amount or get them off. And if a patch will get you there, then it will get you there. So replacement therapy is vital. Many people don't respond to the non-replacement therapy. There are some drugs you can take to help lessen the cravings, but often people need some sort of nicotine replacement to taper off. And I highly support that. But there's no good data, despite what many of the companies would tell you, that switching from cigarette smoking to vaping is healthier. There's no evidence to support that, and I think that's a widely misheld belief, especially among my daughter's 14-year-old friends at high school.
Thanks.
Well, thank you guys so much for being such an attentive audience. I will turn things back over to Joe.
Dr. Wolfe, you're an amazing teacher. Another round of applause, please.